Thank you for the opportunity to talk today. Thank you for the nice introduction. I don't know where that came from. I think my mom wrote that or something. But I guess if you have a long introduction, you can talk less yourself. But anyway, thank you for that. So today, you know, entitled this talk 10 Things to Know About Dementia, but it's kind of a summary of all the things that I've learned over the years about Alzheimer's and dementia. So it's kind of a hodgepodge of different things that I think are important that aren't necessarily always described in a doctor's visit or may not come up with on a website, but things that I've learned and things that I think are helpful. And we'll kind of go through some of that, but I really like the session to be interactive. At the end, we can kind of go through some questions. But these are kind of things that I think are maybe more important that aren't always talked about. I do some speaking for some of the companies, which really nice about what's different about the conference that I went to recently than when it was 3 years ago is we actually have some new medications and they have a place in treatment for Alzheimer's disease. So getting the word out about some of these medicines, I think is part of my job, but so I do speak for some of them. And I think today, what I'm kind of talking about is a little bit some of these lessons I've learned about doing research and clinical practice. It's my 10th year of being in practice. So these are things that I've kind of summarized I think are important. So the very first thing is we'll talk about definitions. If we don't have shared definitions, I think we get into trouble about what we're talking about. And this question about dementia and Alzheimer's, I think that's a good one to start with. Then we'll talk a little bit about the differences and similarities among the different types of dementias, things that I think are specific challenges in dementia and why it's so difficult sometimes to deal with them. And then talking about what are medically available, what are the medical interventions that we can accomplish in dementia, because there's certain things we can help with and maybe reduce symptoms, and there's certain things that unfortunately we don't have good medications for. And then in our practice, we have 4 things that we kind of focus on and that I think affect everybody with dementia, that try to improve their lives and things that we need to have a plan for. So those are kind of the outline for today. All right, so let's start with some definitions. So oftentimes there's some question about what is dementia, because I think they're thrown out a lot as somebody says dementia, this is demented, you have dementia. And the way I think about dementia is when we talk about dementia, we're talking about a group of basically 3 diseases that share the same common output, which is the brain is starting because of a neurologic process to age at a faster rate than it normally would. So dementia is not necessarily normal aging. It's there's a biological or neurologic process that is going on within the brain that causes an accelerated aging of the brain. We don't get to see our brain like we do in the mirror, right? It's protected in a case, a skull case, and so it's very hard to access. But with the advent of images and MRI scans, we can kind of see this during life. It used to be we only see this on autopsy. So here's the difference between a brain of somebody who's 75 and was aging normally, and the difference between somebody with a brain with Alzheimer's disease. We can see clearly the change in the shape. And we've known this for about 100 years when the first doctor who was interested in Alzheimer's identified it in a patient who was only 52 years old. And he was able to, as a deal for her to continue to stay at the hospital where he worked and he could study her, that his husband, her husband promised that after she died that he could study her brain. And so for over 100 years, we've known that the brains of people with dementia change a little bit. So for me, the definition of dementia refers to this common process. There's 3 different major diseases that cause this, but it's a change in the way the brain is aging. So that's the first thing we talk about dementia. Here are the major 3 ones. So there's Alzheimer's disease, there's Lewy body disease, and there's this one called frontotemporal disease. And the thing about these are not always separate. There's overlap. People can actually have both. And in fact, it's more common that a person to have both the Alzheimer's protein and the Lewy body protein in their brain, or to have the frontotemporal protein in the brain. So when I say proteins, that's how we identify these diseases. That's how we determine they're different. Is they're different proteins that are causing the problem. So that brain shrinkage we see is caused by the buildup of proteins within the brain. And the type of protein determines what the cause is. And so people tend to have different proteins as a consequence of their different disease, but they overlap. I crossed off this one called vascular dementia because when people have vascular dementia, they have a stroke and they can have symptoms. But when we're talking about a progressive condition like dementia causing the brain to shrink, I don't think vascular really fits. And some people have been told they have vascular dementia, but they usually have something else. So when you have vascular dementia, you usually have some small strokes and you probably have Alzheimer's disease as well. So if we go back and say, what is a dementia disease doing? It's causing the brain to shrink. And there's three different types of diseases, and the difference is the protein. And where the protein affects the brain causes the symptoms. So I know it's getting kind of complicated, but if we stick with this idea that dementia refers to these three different diseases, their outcome is that the brain is shrinking. I kind of have a better sense of when I use the term dementia, when I say to a person, you have dementia, I'm referring to one of these three conditions that's
Ritter.
causing the brain to have some age changes.
Rinking.
So, okay. So the other thing to say is, well, how is dementia different from normal aging? And it's primarily in the symptoms. So these are the common symptoms we start to worry about with dementia. Is you'll see on here, forgetting people's names or occasionally having a word finding problem is not on the dementia list, because that's not a symptom of dementia. That's a symptom of normal aging. So when we start to think about people having symptoms of dementia, they may repeat themselves over and over again, may tell the same story. Dementia runs in my family, by the way, and I have family members with it, and they may tell the same story over and over again. We've heard it multiple times. So that's different than forgetting the name of a neighbor. The ultimate symptom that all the dementias share is we lose some of our functional abilities. So things that used to be easy, for example, paying taxes or doing the bills or managing the household, that's the overall outcome of dementia is we lose some of our functional ability. One of the other symptoms is problem solving. Getting problem solving is difficult for somebody with dementia, especially as the disease progresses. Some dementias cause behavioral changes, and we don't know why some people get behavioral changes, but not everybody gets the behavioral changes. They're very striking when they happen, because some people, as a consequence of their dementia, they can become very angry or very confrontational or agitated, and that's a product of their dementia. So the dementia not only can cause cognitive symptoms, but sometimes it causes behavioral symptoms, and sometimes it doesn't. And the only problem is a memory problem. We don't know why. We think it's probably a combination of genetics and where the brain disease is happening and underlying personality. The other thing we see in most dementias is there's changes in metabolism. People with dementia tend to lose a lot of weight as the disease starts to occur. So we really need to pay attention closely to weight changes. There are often changes in how our body handles cholesterol. So cholesterol is a common one. And overall, all the dementias share the same quality, which is the symptoms tend to get worse over time. They're slow, so dementia should not cause quick changes in our memory, but it does continue to worsen. That's a common feature among all the different dementias. So in normal aging, that's a little bit of a different story. So people with normal brain aging that don't have dementia, we know that the product of age, starting after about the age 25, our brains are getting smaller. We have difficulty with multitasking, so keeping track of multiple things at once. The speed with which we get cognitive activities done changes. We get slower at doing things. I know that's true for me as I'm learning a new technology or learning something new or learning a language. You think about teaching a 12-year-old a new language versus teaching a 22-year-old or a 32-year-old or a 42-year-old, the speed with which we learn that language tends to go down. So that's kind of normal aging. That's not a dementia symptom. Learning new things tends to be a little bit harder as we get older. And I say getting older includes anybody over the age of 25. That's when our brain starts to get a little bit smaller. So learning new technology. So people come to our clinic and say, well, I think I have dementia because I'm having a hard time learning how to use a new telephone. And by itself, that's not enough of a symptom to be worried about for dementia. But learning gets to be hard. The process of learning is harder as we get older. That's why we do most of our learning when we're in school. So I see kids dropping out of school. I said it's a crucial time in their life to learn how to learn. That's when we do it best, when we're young. This other thing that happens is memory retrieval. Sometimes we have these memories in our brain. We can't pull them out. This commonly happens when we're watching a TV show or a movie and we see an actor on the screen and we know who that guy is or that girl is, but we can't remember her name. And then later that night we say, "Oh my gosh, I can't remember. Can't believe I forgot the name of that actor." That's a retrieval problem. So it's in there. We just can't quite get to it. That's not a dementia symptom. The dementia symptom is that it never got stored in the first place. So for example, when I used to go and visit my grandmother in Florida, I would go and visit, and when on the way home, I would call her back and say, "I made it home." And she said, "Well, when are you coming to visit? You've never visited me." And I said, "I was just there this weekend." That's a consolidation. That memory never got consolidated. That's different than pulling out a memory we all have in our past. So it's kind of a different thing. So the type of memory that's affected can kind of give us a clue as to whether it's dementia or normal aging. So having these retrieval problems of being like, geez, I know the answer to this question, I just can't quite pull it up. That's not necessarily a dementia symptom. When somebody kind of goes through the same thing, like they've never heard it before, that's different. So memory is kind of complicated in that regard. So these are the things that I don't get too worried about. The word finding problems occasionally, being able to retrieve the names of people, especially people we haven't seen for a while, that's not concerning. If it's somebody that we know really well, like a family member, um, so those are things that are a little bit more concerning. But if it's a neighbor down the street you haven't seen for 6 weeks and you can't remember his name, that's not a dementia symptom. Forgetting some items on the list, going to a store, that's a retrieval problem. We know it's there, we just can't pull it up. That's not concerning. And then there's this common phenomenon that our brain goes through is when we go into a room, there's a little switch that's flipped in our brain's functioning. And so it's very common as a phenomena of entering a new space that our brain kind of does this thing where it switches over its network and momentarily we forget something. So that's not a dementia symptom. That seems to be our brain's attentional system flipping over. So anytime we go into a novel situation, our brains can sometimes have a memory glitch. So it's very common for people to go into a room and forget what they're doing. It happens to me when I go into the garage. It seems like every time I go into the garage, I forget what I'm doing because it's a novel situation, but that's not a dementia symptom. And then we talked about technology. That in itself is not sufficient enough to make a diagnosis of dementia. The other way we use the term dementia, so we talk about dementia referring to this umbrella of three conditions, is the stage. So this is a remnant of kind of the sort of older time when we kind of equivalated. We said Alzheimer's is always dementia, but we know now Alzheimer's can start with milder symptoms. But another way we use the term dementia is the stage. So there's different stages of dementia, and so sometimes we say a person's reached a stage of dementia. That just means that the person can't live independently on their own. So there's two definitions. One is about the diseases, the three diseases. The second is the stage when a person can no longer live alone. So I go back to my family. My grandmother was living with my grandfather in Florida. They were both in their late 80s. My grandfather died from an unrelated neurologic condition. He had a heart condition. And when he passed, my grandmother could just not pay the bills or take her medicines or remember to keep fresh food or ingredients in her kitchen. So she couldn't live independently. So she was at a stage of dementia, and the cause was one of those three diseases. It turns out she had Alzheimer's disease, but not only we're describing the symptom or the cause, but we're also describing the stage. If she could kind of do it on her own, we'd say she has Alzheimer's disease, mild cognitive impairment, but she had Alzheimer's dementia. So it's kind of confusing. We can come circle back to that, but there's two ways that we use the term dementia. One to describe the diseases, the three separate diseases that kind of cause similar symptoms, and the stage of the disease. So we'll kind of go through that more. So oftentimes people will ask this question, is it Alzheimer's or is it dementia? And that's because historically we said that they were equivalent. No longer is that the case. Alzheimer's is a specific disease. It's under that umbrella of dementias. And dementia is the stage of Alzheimer's. So when you say Alzheimer's dementia, you're referring to a disease and a stage. But you can say a person has Alzheimer's with mild cognitive impairment. They're not quite to that stage yet. So they're separate things. One is not worse than another. They're both kind of describing the same thing. So you could have dementia due to Lewy bodies or dementia due to this condition people get when they box for too long or they hit their head, to CTE or chronic traumatic encephalopathy dementia. So when you say dementia, you're using the stage, but dementia and Alzheimer's are kind of similar things. They're similar terms. So one's not better than the other. So I often get this question, is it worse to have dementia or Alzheimer's? And that's a hard one to answer because most of the time when a person has dementia, the cause is Alzheimer's, and we're referring to the stage. And it turns out that the age of when a person gets dementia is important. So if you get Alzheimer's disease, we have patients as young as 45 or 50 getting Alzheimer's disease, and they're at the dementia stage. So they have Alzheimer's dementia because their brain has been affected. They can't live independently. They have Alzheimer's dementia at age 45. It's a much different than if you get it at age 85 or 90. In general, people who get the disease a little bit older in life have a little bit more of a natural resistance to it. For whatever reason, their brain is a little bit more able to affect the disease. So I think the age is important. And for me, the cutoff line is about 75. If it's 75 or younger, it tends to have more of a genetic component to it. If it's later than that, less of a genetic component. It's not always the case. But what we're seeing is people who use their brains, who exercise, who learn new languages, who do a lot of physical and cognitive activity, they can push the onset of their Alzheimer's disease or the dementia later into life. So for me, the age of onset is important. I do think personality, so a person's underlying personality is important to how their symptoms may be. Their health is important. So people that have strokes or have a lifelong history of having damage to their brain, and then they get Alzheimer's disease, that affects things. Their environment is important. So a person's living environment is important to how their dementia symptoms may manifest. So if people are in a high stress environment and they have dementia, that may come out in different ways than it normally would. And for me, the type of dementia matters a little bit, but not so much because they share so much in common. I don't spend a whole lot of time determining the difference because in reality, a lot of times people can have both versions. So they can have the Alzheimer's protein, they can have the Lewy body protein, they can have some small strokes. So for me, the cause is not as important as I think a lot of people get hung up on. So in general, I think I talked about this before. Over age 85, people ask me, is this Alzheimer's disease? And it's hard to answer that question because everybody over the age of about 85 or 90 starts to have a little bit of memory problems. They don't remember things as well. But unlike people who get dementia under the age of 75, they can really remember how to do things, and it's easier to kind of take care of things and remember, to do hygiene and shower and be able to drive and things of that nature. But people who are younger start to have dementia. I get a little bit more worried. We have this kind of new thing called PART or PART. That's a description of somebody over the age of 85 who has memory problems, but they don't have Alzheimer's. So I think this also runs in the other side of my family was grandparents that were in their 85 or 90. They didn't remember very well, but they could kind of really remember to do a lot of things. They just needed a couple of reminders. It's different than my other grandma that had Alzheimer's disease. So both things kind of run in my family. So if you're over 85, it's people are going to have some memory problems. Whether or not it's Alzheimer's is not always clear. And then there's always a question about what does Alzheimer's disease? What is it? We see stats about Alzheimer's is the sixth leading cause of death. in general, people younger than 75 who get Alzheimer's, their disease may cause their body to shut down. And so people can die from Alzheimer's directly. Whereas people over the age of about 85, it's usually something else. So this is complicated stuff because I think age is important. So I take into consideration when a person gets dementia to kind of describe what the symptoms may foretold. And so these are just the different proteins in the brain. And in general, if I hear somebody's got Alzheimer's at age 65, find it different. In my mind, that's different than somebody who gets Alzheimer's at age 85 or 90. So for me, age is an important one, and it helps. I think it helps folks plan and to think about how that is. So oftentimes we learn things from our celebrities because that's where the media portrays symptoms, and it resonates because we know these people. These are shared almost like family members. So an example of somebody that we know had Alzheimer's disease is Ronald Reagan. It turns out that Nancy Reagan was a very big advocate for Alzheimer's disease. So there's many things in the Alzheimer's disease world that are named after Ronald Reagan, including how we rate the autopsy. So when people have autopsies in Alzheimer's disease, it's rated based on the Ronald Reagan criteria. So he's somebody we learned a lot about for Alzheimer's. We think he got the disease a little bit later in life. So I think he was close to 80 when he got the symptoms. So his symptoms were a little bit more less noticeable. He didn't have a lot of problems with his speech and other things like that. That maybe a younger person with Alzheimer's, but his condition was a progressive memory loss that got worse over time. So he could, as he got longer in his Alzheimer's disease, his memory for long-term events was better than short-term events. So he could remember things from his childhood better than he could, for example, what he did yesterday or the day before. So he's an example of somebody with Alzheimer's disease where the problem was short-term memory. So progressive loss of short-term memory. Margaret Thatcher also had changes in her memory that were identified and later were determined to be Alzheimer's disease. So she also had those that syndrome of progressive memory loss. And in Alzheimer's disease, we tend to get difficulties with forming new memories, with intact long-term memory, some difficulty with multitasking. And then along with that, pretty much most people with Alzheimer's disease tend to have some personality changes that can be a little bit, sometimes, not everybody, tend to get a little bit more frustrated or irritated with our memory. Lack of motivation to do things. So hobbies and things that we used to like to do. And I think Nancy has described how Ronald changed in these ways. He wasn't as motivated to do certain hobbies and activities. And then some people get anxiety. So these are kind of more on the sort of in typical, these are the most common symptoms that we notice in people with Alzheimer's disease. Lewy body disease is kind of a very different dementia syndrome in some ways because it's very closely related to Parkinson's. So I tell people Lewy body and Parkinson's are very similar in that our brain is changing along with our body, and that results in some other symptoms. So Robin Williams' widow actually came and talked to a group of doctors and was very described some symptoms he had where he would see things, he could see animals and things of that nature. So he had hallucinations. He was very sleepy, so he took a lot of naps. And they had some physical changes with really low blood pressure, where most people, as we get older, our blood pressure goes up. People with Lewy body disease tend to have lower blood pressure, constipation, and this very vivid acting out dreams, not just talking, but throwing the body and punching and kicking at nighttime. So Lewy body disease has slightly different symptoms, but in general, Alzheimer's and Lewy body overlap because it's slowly progressive changes in our brain's functioning. Then rarely there's a condition called frontotemporal disease where it's a disease that affects a specific lobe of the brain, or it's two lobes of the brain. We have four lobes in our brain. Frontotemporal dementia, for whatever reason, affects either the temporal lobe or the frontal lobe. If it's the frontal lobe, we get behavioral changes. If it's the temporal lobe, we get speech changes. So Bruce Willis, very famous actor, he has temporal dementia. So his dementia only affects the temporal lobe, and this showed up when he was trying to memorize lines or speak. He couldn't really speak, so it's a dementia of speech. And that's the only thing that's typically affected early on in the disease course. So it's a different kind of condition. So for him, his symptom is speech difficulties. That's frontotemporal dementia. It's a little bit more rare, and for whatever reason, it has a predilection for a specific lobe of the brain. We don't know why. Um, these are the pathologies we talked about. What is dementia? Dementia is really the accumulation of these proteins in the neurons or the cells of the brain. And the protein's different between each of the different conditions. So we have amyloid and tau in Alzheimer's disease. We have synuclein, which is the protein that we see in Lewy body disease. And then we have tau in frontotemporal dementia. So these are the different proteins. It turns out when we look at autopsy studies, about 80% of all dementias are caused by Alzheimer's disease. So even if a person gets diagnosed with something else other than Alzheimer's disease, 4 out of 5 times it's Alzheimer's disease. And you can have both. So I don't spend a lot of time trying to distinguish between the different ones because there's a lot of overlap. And even though Robin Williams had very striking symptoms, it's pretty rare just to have one disease. So I didn't spend a lot of time going through that. One of the things I'm really interested in is trying to predict what the behavioral changes may come, because people say, is my mom, is my spouse, are they going to get angry and mean? Because we have this perception that everybody with Alzheimer's disease gets to be angry or nasty or mean or things like that, or starts wandering or does different things with their behaviors. But the reality is that's not true. Only a certain percentage, a smaller percentage of people get those very striking symptoms that we can read about. They're very striking. And so it sticks in our mind that anytime anybody gets Alzheimer's, they're going to start wandering or start becoming aggressive or things of that nature. And that's not reality. That happens to a small percentage of people. But if we think about personality and underlying personality, in general, we have a couple of different domains that we can rate a person's personality, and they kind of come out. There's 5 different ways we can rate a person's personality. So one is whether we're open to experience. These are the explorers. These are the people that like to go to a new restaurant or like to travel to new places or try new things. And then there's the folks that are cautious and consistent. And so that's a domain. And so you kind of exist on that spectrum of being really adventurous or not that adventurous. The other one is conscientiousness. So are you conscientious or are you kind of carefree? That's a different domain. Are you introverted or extroverted? Are you agreeable? Are you friendly and agreeable? Or are you kind of critical and rational? So that's a agreeableness. And then neuroticism is how sensitive are you? How nervous are you versus how resilient and confident? So if we can kind of rate a person on these 5 different domains. And it turns out that when a person may get dementia, we see everybody gets a little bit more anxious and nervous. So people that are worried about things in their mind, they've always been kind of a worrier. If they get dementia or Alzheimer's disease, that worry tends to peak up a little bit. So if you're really worried at the beginning and we get dementia, we kind of have to anticipate that anxiety may be more of a problem. But if you're a surfer dude with no carefree in the world, that anxiety doesn't usually go up to be that high. So we can kind of anticipate what sort of symptoms will come up. Everybody gets a little bit less conscientious. I think that shows up with the sort of, like, I think it often shows up with willingness to shower. I know that showering is this big event a lot of times for folks with dementia, and it tends to be that goes down for everybody. But if you're this military person or your whole life taking 2 showers a day or always showering, making the bed, I think that's less of an effect, whereas other people may be more affected. We see decreases in extroversion. So people that used to be the life of the party, if they get dementia, they're less likely to be wanting to do social activities. So that can be a striking change because oftentimes our partnerships are based on these underlying personalities and then they change in dementia. That can be hard. So it's often common for people that are very extroverted to become less introverted. And if you're introverted already and a person gets Alzheimer's, that tends to be one of the big challenges, getting somebody to be motivated to do anything. Openness, we all tend to get a little bit less open as we get older, and then agreeableness. And so this is the one I think that leads to agitation. So there's a lot of unagreeable people in our lives. We all know who they are, and when those folks get dementia, it tends to be one of the things that is a challenge because we can get quite frustrated, irritated, agitated. So those are the things that we think about. For me, this is the most challenging part of dementia, and this is this concept of anosognosia. It's a fancy way to say lack of awareness. So most people, and I think it's close to 90% of people that have dementia, particularly Alzheimer's disease, really aren't aware of their deficit or aren't aware of their problem. And I had a mentor of mine that said, well, people who don't remember that they don't remember that they don't remember. And so for me, that's something I always have to keep in mind. So somebody with Alzheimer's or dementia, they have short-term memory problem, they're not aware, oftentimes they're not aware of their limitations or not aware of their condition. That makes it really hard. It's really hard to take care of a person or to help somebody that doesn't want help. And that's what the caregiving is when it comes to dementia, because people aren't aware. And this shows up in our practice a lot of times around driving, or shows up around wanting to manage finances and wanting to manage medications. And sometimes folks don't understand. And family members that aren't often very close or don't quite understand the disease don't really get this. And so they see the situation of somebody say, well, you have dementia, that and so you need to stop driving. And for most people with dementia, that doesn't resonate with them because they have this condition called anosognosia. So anosognosia uh, impairs our understanding of our own problems. So it's really sometimes hard on caregivers who are living with people that or living with a patient that may not understand the limitations of their problem. So it can feel a little bit like this concept of always having to remind or always trying to be aware. And we try to do some appointments where we can, in every situation we can, where we try to do things a little bit separately so we can kind of have the real conversation, because a person with dementia may not quite understand that. One of the other things that I really sort of learned from dealing with this condition is that things we don't talk about when it comes to Alzheimer's disease is oftentimes we see deficits in what we call emotional intelligence. So one of the first things that often changes is a person's, similar to that anosognosia, lack of awareness, is lack of an understanding of how another person feels. So for example, um, if a person has a particularly stressful day, we'd like to hear from our spouse or partner or friend, how are you feeling? That must have been really difficult, or that must have been a really challenging situation. And we know as a product of this condition that emotional intelligence, those kind words, the empathy and sympathy, they may have already been changing. And patients with dementia aren't as aware of those emotional states as we used to. So that sort of back and forth and conversations may change because we don't get that feedback. We don't People don't ask, how are you doing? How are things going? That's an emotional intelligence. That's a product, I think, of having dementia. That changes, and folks aren't as aware of that. So it can be really challenging, especially on spouse relationships. I have family members that have grandchildren, and they say, well, I kind of knew when dementia was starting because my dad stopped asking about how my kids were, and that's really hard. But that often is something we see, and it makes it really hard on spouses because that same emotional connection really isn't there, and that's a really difficult thing. And hopeful that in the future, if we get able to treat dementia, we'll be able to improve this emotional intelligence. But we don't talk about that a lot, and I think a lot of caregivers suffer from that because they're not getting that sort of feedback that they used to get. Here are the specific symptoms that are common. We talked a little bit about that. These symptoms we expect, the behavioral changes that come with dementia for whatever reason, apathy, the lack of motivation to do hobbies or to do activities that used to be really exciting and really fun. For whatever reason, that spark oftentimes gets extinguished. And so an avid golfer or avid bowler or avid shopper may no longer be interested in doing those things. It's really hard and shows up to look a lot like depression, but it turns out it's not depression. Depression is sadness, and emotional sadness, and that's not what we see. And this is apathy. Apathy is a lack of just a spark and motivation to do things. Other symptoms are kind of hit or miss, or they may come and go. And so some people get delusions, which are false beliefs and hallucinations. And then some symptoms are more likely to persist. They tend to get worse over time. And if a person is kind of agitated, that may get worse over time. It may not. So these are symptoms that are a little bit common. If we kind of group things, this is kind of, I think, helpful to understand these different groupings of symptoms. When scientists have looked at the different subtypes, there's behavioral subtypes of people. There's the agitated subtype. That's the patient who gets really frustrated when they're told to take a shower, or they don't remember something, or they can't drive. So there's a subtype where we see agitation as the primary symptom. There's the depressed subtype, people who get sad that they can't remember. And so those people are more likely to have depression. There's one called the psychotic subtype where you have hallucinations or false beliefs, feeling that somebody's stealing something. So that's the psychotic subtype. And then there's the manic subtype where the consequence of the dementia is not that they lose their motivation, that they're actually elevated. They have more energy. They talk to everybody. They're disinhibited. They go up to people on the street and act like they're their best friend, or they pick up a baby at the restaurant, or things of that nature. So these is different subtypes. It turns out that the manic subtype, that one that's disinhibited, talking to, that's pretty rare. And the agitated subtype is kind of the more common one. That's about, I think it's about 20 to 25% of people have the agitated, but 4 out of 5 don't. It's just that 1 in 5 is kind of striking when we see it. Depressive is a little bit less common. The depressed people tend to have a little bit of anxiety too with it. So these are the different subtypes, these patterns of behaviors we see in people when they get dementia. This is a question I think a lot of doctors and medical providers don't really answer the question: what is the role of the medical provider? What can medications do, and what can doctors and physicians do to help with dementia? Because there's somewhat of a limited role. We can't solve the problem. It's not like a broken leg we can put a rod in and fix the problem. With dementia, it's a little bit different. So I think the first thing is to ensure that we have the correct diagnosis. There's certain things and certain vitamins and certain conditions that can mimic dementia, and those are called pseudodementia. So people can be depressed, and that can cause something that looks like dementia. People can have changes in their vitamin levels, particularly B12. I've seen people who have horrible sleep patterns, and that's the cause of their dementia. We call those pseudodementia. So doctors can kind of help determine whether or not it's a pseudodementia or a true dementia. And then they can also help with doing things like capacity evaluation. So there's legal laws to kind of determine when a person can no longer manage their bank accounts because they're spending frivolously. A doctor can help with the capacity determination. What else can medicines in the medical profession do? Well, I think we can help with cognition a little bit. And so we have no cures for cognition. Cognition is thinking and memory and language and problem solving in general. Medical and the medical field and medications have kind of small benefits. The primary benefit is on stability. And so this is the results of a study with that medicine, Aricept or donepezil. And in this study, what it shows is that people on the yellow line on the treatment got a benefit above that of the placebo. So people say, why should I take this Aricept or donepezil? It doesn't really do anything. But when we do studies, what it shows that over time, the benefits are kind of like a vitamin. It boosts our brain. It doesn't cure the problem, but it gives the brain a kind of a little bit of a boost. So in general, I think there's some benefit for taking these medicines, but the benefit is kind of short-lived, and it may not, certainly not a cure. The other thing a medical doctor can do, or a medical provider, is can look for other contributing factors. So if we have untreated sleep apnea, that makes memory worse. If we have vitamin deficiency, that makes things worse. If we have high risk for stroke, we can take medicines that reduce our risk for stroke. There's these new medicines, and this is probably the biggest addition in the last couple of years, are these antibody therapies. These antibodies slow down the rate at which we lose cognition. They're not cures, they don't reverse the condition. They give us some benefit over doing nothing, but the benefit is really on the sort of time scale of about 6 months. That's the biggest benefit people got in these studies. We got 6 months of better brain function out of treatment. They have a lot of side effects, including this thing called brain swelling or ARIA. In this picture, we see this person with this white area up there. It's usually not symptomatic, but some people get a headache when they have this. So these medicines have to be carefully taken. So they're not for everybody, but they do provide a little bit of a benefit. What else can medical providers do in terms of treating the symptoms of dementia? Well, I think we can do a little bit better on some of the behavioral symptoms than we can on cognition. So if a person's agitated, we usually can get about a 30 to 40% improvement in their symptoms. So they're less frequently agitated or less severely agitated. We have no benefit on that apathy thing, that motivation for whatever reason. No medicines really work that well. If a person has hallucinations, we can usually treat those completely. So if a person has hallucinations, that's where medicines can really help. Delusions, those tend to be harder to treat. So if a person believes that somebody's out to get them or there's something wrong, that somebody's stealing stuff, that tends to not be treatable that well. But oftentimes it's less emotional, so we can reduce how bad that bothers somebody. So oftentimes we try to treat delusions. Depression we can treat, and we can often get depressive symptoms a little bit better. So if a person with dementia has depression, we can usually treat that. And that mania, that increased energy, the go, go, go all the time, that a small percentage of people, we can get some slight improvements in that. So here are the 5 things that we tend to focus on in our practice that all people with dementia, no matter what version of dementia, no matter what stage they're at, this seems to be kind of affecting and these are important things, and we tend to call them the 5 things of dementia. There's the pills, the bills, the thrills, the spills, and the spills. And so we'll kind of go through this really quickly. So the pill part, that's huge. And I'm trying to talk to all my colleagues about the idea that when a person has dementia, it's really hard to manage medications, whether that's remembering to get them refilled or remember that to take them every day. And every stage, if we get dementia, it's harder to manage. So with a person at stage 4 dementia, they pretty much need somebody there to help remind them to take medicines. The pill boxes only kind of work in stage 3 or the pill box reminders. At stage 4, we're pretty much at the level where somebody needs somebody to help remind them to take their medicine. And that's a big deal for certain medicines, is less of a deal for others. But things like diabetes medicines and blood thinners and heart medicines, we have a lot of people that stop taking them because they forget that they have to take them, and that can become a medical emergency. So we talk a lot about pills. Bills is a big one. So finances become really hard. It's really complicated, all the way that automatic bill pay and everything is coming up. So we find that that's a challenge. We want to have somebody at stage 4 have some uh, help with managing their finances. I do like this Life a Lock, which kind of gets us some um, protection on that. Driving, for whatever reason, when a person has a memory problem, they don't necessarily forget how to drive, but they forget how the roads are connected. That just seems to be where the memory center of the brain and the navigation center are very closely linked. So the driving issue is around navigation. So we've got a solution around how to get around, not so much how to drive, but how to get around. In California, there's strict state laws about who can drive and taking the driving tests. Nutrition, for whatever reason, the motivation to eat, that apathy part, goes down, or people have changes in their smell. So oftentimes we see big loss of weight. And so reminding people to eat, and if they're not eating as much, that they should be getting most of their sources of food from protein. That's super important. And for whatever reason, a lot of people with dementia get kind of a sweet tooth. I think that's because their brain is working extra hard to remember things. So we see a lot of sweet tooths. The problem with having a sweet tooth is it doesn't fill the tank very well. It's only about half the value of protein. So we tend to support protein. Falls are a big one. That's for everybody. And I think it's dementia unrelated, but for people with Lewy body disease, falls are a big issue. If we can prevent falls, that's super important. So we want to pick up things on the ground and have some assistance. I know I'm kind of running out of time, so I want to get to a couple questions here. This is the very last thing. We're working on algorithms so we better understand this, because I think most people get a diagnosis, but they don't really know what to do with the information around the diagnosis. And that's why organizations like Cognitive Care Solutions are so important, and having the repeated follow-ups. In our clinic, it's hard for us to keep the volume of visits, the frequency. So we want to have organizations that know about the condition kind of help educate people on the disease. So for me, these are kind of the things I I find, and these are the ten things that I've learned over the past couple of years. So I'll maybe open to questions.